And as an introduction, shock can be defined as inadequate tissue oxygen for aerobic cellular respiration. Basically, this is kind of like a mismatch in between the supply and demand of oxygen. And it can be due to reduce in the supply or increase in the oxygen demand by the cell. And regarding the cause, it can roughly divide into few classes here. You can be due to a hypovolemic shock, or it can be due to cardiogenic shock, alteration of vasomotor function, as well as obstructive shock. Although it's rare, but sometimes we have to think of the obstructive shock, because usually patients with obstructive shock need the immediate intervention for life saving. For example, causes of it will include the tension pneumothorax, the cardiac tamponade, as well as the pulmonary embolism. And the diagram illustrated here basically show you the pathophysiology of shock. Macrocirculatory failure basically means there's a reduce of blood flow in the big vessel. For example, arteriosclerotic plaque in the carotid artery, cerebral artery, coronary artery, as well as the lower limb artery. So because of the reduce in the blood flow, it usually causes necrosis in the affected organs. Microcirculatory failure basically means reduce the perfusion in the microcirculations, the smaller vessel. So one of the good example is the acute tubular necrosis. All the kidneys are the first organ. They are going to go down because of the shock. Kidney is very sensitive to all this blood flow. If you get the shock, the first organ, they are showing a signs of poor perfusion with kidney. It will be the patient usually will present with the reduce in the urine output and also the increase in the metabolic acidosis. And apart from a circulatory failure, there's also a cellular level of mismatch between the demand and supply. For example, if the patient got an increase in the oxygen consumption in the cellular level, it will cause tissue hypoxia as well. Example of this will be the mitochondrial dysfunction, sepsis, stress, or other physiologic compensation that increase the oxygen demand. And because of all these circulatory failure as well as tissue hypoxia, eventually patient will develop anaerobic metabolism and lactate production. And acidosis set in, the patient usually will progress into multi-organ failure and death. And cardiogenic shock is basically one of the common scenario that cardiologists need to deal with. So the definition for cardiogenic shock basically is a shock as a result of low cardiac output. So you have to exclude hypovolemic shock before you can diagnose this condition. Cardiogenic shocks is always associated with the elevated filling pressure, either the left, right, or both ventricles. Cardiogenic shock will present in 4 to 8% of the STEMI MI, 2 to 3% of the non-STEMI. And 80% of cardiogenic shock caused by acute MI usually is due to ventricular dysfunction. Another 20% of the cardiogenic shock is due to acute decompensation of the pre-existing cardiomyopathy, valvular heart disease, Takotsubo, myocarditis, and electrical storm, as well as patient post-cardiotomy. And like always, the general rule saying that if the patient presented with cardiogenic shock, about 50% of them will die during the hospital stay. And one of the sad things about this cardiogenic shock is that the diagnosis tends to be delayed because we have several different definitions for it, and definitely we have different criteria to diagnose cardiogenic shock from one hospital to another hospital. And listed here is basically different criteria to diagnose this syndrome from several trials here. And I usually prefer to use the criteria stated in the shock trial in 1999. Basically, you need to fulfill 3 criteria to say the patient got cardiogenic shock. The first criteria will be the hypotension. Second is end organ hypoperfusion. And the third, you need to depend on the hemodynamic parameter, defined as a cardiac index of less than 2.2 and the wedge pressure of more than 15. And how to classify? We classify shock according to the severity. So this shock stage classification got the 5 stages of shock. A stands for at risk. Those patients presented with a risk of cardiogenic shock. B is the beginning of shock. Basically, this group of patients will start to have hypotension, but the body can still compensating by generate, the minimum cardiac index that maintain the circulation of the body. You can see here the cardiac index still more than 2.2 after the tachycardic compensations. And C, classic shock. Basically, the patient fulfill all the criteria for cardiogenic shock. D, deteriorating, basically means those patients started on treatment but continue to deteriorate. E basically is the end stage. Either the patient got asystole, pulsed electrical activity, or the patient on maximum inotropic support. And how do we assess the hemodynamics of our patients? Basically, we have to do this from our routine clinical practice, just that maybe we didn't realize. So the method we use to assess the hemodynamic of the patients will include the clinical assessment, the bedside evaluation with the central venous catheter and arterial line, the laboratory, electrocardiogram, and echocardiogram. So according to the heart failure guideline and Stevenson classifications, for heart failure patients, usually we need to assess their hemodynamic and try to classify them based on the perfusions and also the fluid status. So there's 4 groups here, which you are quite familiar with, the diagram over your right-hand side. But in context of shock, we just want to identify those patients with poor perfusion. Basically, we just want to identify those patients in cold, either cold and dry or cold and wet. So how do we know the patient have a poor perfusion? Symptom-wise, the patient tend to have an altered conscious level, poor appetite, weight loss, profound exercise incapacity. Signs to suggest low perfusion will include low blood pressure, narrow pulse pressure, resting tachycardia, weak pulses, cool extremities, and poor urine output. And this show you the several laboratory as well as imaging evaluations. So for example, those tests that identify patient at risk of shock will include the biomarker. Troponin T increase indicating that the patient got myocardial necrosis. Natriuretic peptide level identify the patient to have heart failure. This as well as for the chest X-ray show you the cardiomegaly, 12-lead ECG diagnosed with ACS, pulmonary embolism, acute myocarditis, so on and so forth. And you also got the laboratory test that can show you the marker of hypoxia. For example, the mixed venous oxygen saturations, the lactic acid level. Marker of end organ hypoperfusion, your kidney functions, your liver function. And some of us will use the echocardiogram to try to calculate the cardiac output by measuring the aortic valve PTI, measuring the lateral mitral annulus peak velocity to roughly estimate the cardiac output non-invasive way. And why we still need the advanced hemodynamic measurement? We already have our routine clinical practice that can assess the hemodynamic, but I would say most of the time we still need this advanced hemodynamic measurement? The reason number one is our clinical skill or clinical assessment can be very difficult to diagnose patient. So for example, for the patient with multiple comorbidity, patients, we can't really tell the patient have what type of shock here. So just give you a a simple example. A patient with advanced kidney failure and low EF coming with high-grade fever, then presented with shock. So this group of patient, how do you determine this patient got hypovolemic, cardiogenic, or even sepsis? You won't know. From your clinical assessment, you can't tell which type of shock are there. And another thing is that the signs of congestion, for example, raised JVP, is not specific. It can mean a lot of things. Either the RV failure, pulmonary embolism, cardiac tamponade, or it can be due to left heart failure, or it can also due to arrhythmia. So once a sign that show to you cannot tell you the further information, what is the underlying cause? Of course, you can't treat the patient without knowing the underlying cause. And physical signs that you can pick up from your physical examinations tend to lag behind the hemodynamic changes. So you might having a delay in the diagnosis if you can't get the patient's hemodynamic measurement. And of course, our patients tend to be not stable. Cardiogenic always is rapidly changing conditions. They have fluctuate hemodynamics. So you can't be standing there beside the patients, monitoring the patient from second to second. I mean, you still need to go home. You still need to see your patient in the clinic. So you might want to use all these tools to help you to monitor, make your life easy, and of course, try to produce a better outcome for the patient. So advanced hemodynamic measurements can provide the bedside direct and indirect measurement of all the major determinants of cardiac performance. So it's more accurate than your physical examination because it can tell you the fluid status, the pre-root, after-root of the right or left ventricle. It can also tell you the cardiac output. And for those patients who have isolated right ventricular failure, even pulmonary hypertension, I think you have no choice but have to do the invasive swan gun catheter to get their RV feeding pressure and also to calculate the pulmonary vascular resistance. And the advanced hemodynamic measurement also serve as an important tool to diagnose, to classify according to severity, and to support your clinical decisions. And like I mentioned just now, all these monitoring tools can help you to monitor the treatment you give to the patients, whether you are giving the right thing, the wrong thing, whether the patient is responding throughout the whole treatment course. And of course, this hemodynamic also guide the therapeutic choice regarding the volume optimizations, type of vasoactive drug you need to give, whether it's enough or not, whether you need to escalate up to the mechanical circulatory support. And like I mentioned, if the patients have shock, fail to respond to the initial vasoactive agents, and you want to escalate to the mechanical support, you also need to use the hemodynamic parameter to decide whether this patient have LV dysfunction, RV dysfunction, or both biventricular dysfunction. So how you tell that is basically you need to get all these reading. This will include the wedge pressure, the CVP over wedge ratio, the pulmonary artery pulsatility index, cardiac index, systemic vascular resistance, and also cardiac power output. So how do you get this reading? You cannot get from the physical examination. Definitely you cannot get from the echocardiogram. So you only need to use the invasive hemodynamic to tell you all this. And of course, talking about the good thing, definitely there's a disadvantage of all this advanced hemodynamic monitoring. So we are talking about the complications. So when you're inserting the line to get all this reading, there's always a risk of complications like hematoma, arterial puncture, arrhythmia, infections. If the swan gun pushed too in for a long time, it will cause pulmonary infarct and even pulmonary hemorrhage. And I think most of you is concerned about whether this advanced hemodynamic can give you a better patient outcome. Lack of actually all this is lacking of robust data. It didn't really show that it can improve the mortality of the patients. And sometimes this advanced hemodynamic also give you headache also, because you will see a lot of confusing data. It's not really tally to what the clinical picture tells us. As such, you need to, I would say, have more experience using it and try to create a protocol how you should deal with all these situations. And type of advanced hemodynamic monitoring, there's a lot, but this highlight here is basically those are the advanced hemodynamic I used to I'm more familiar with. This will include the invasive pulmonary arterial catheter, the fourth track, which is your pulse control and pulse pressure analysis, and you have your echocardiogram. Of course, we still have other types of hemodynamic profile, which I would love to explore if possible. And regarding the guideline, I think the guideline only say one thing: the invasive pulmonary artery catheter. These are the recommendation for the guideline. So you can see from this table to 2013 ACCH AHA guideline suggests you to use the pulmonary artery catheter when the clinical assessment is inadequate. After your clinical assessment, you still don't know what's going on for your patients, then it's time to escalate up to the more advanced monitoring. And the standard class 2A indications to use in the acute heart failure patient with persistent symptom despite the empiric adjustment of the standard therapy. Means after you start treatment, the patient doesn't progress to the direction you want the patient to be, then it's time, to ask again yourself whether you're making the correct diagnosis, whether you're giving the correct medication for the patient or not. So it's by inserting all this advanced monitoring and prove that. And of course, all this PAC is not recommended in a patient without shock, without poor perfusion, and definitely is not for those normotensive patients. And the SCAI Heart Failure Society of America doesn't give any level of recommendations, but it also suggests that in order to diagnose a cardiogenic shock, you need the pulmonary artery catheter, and this pulmonary artery catheter should be used also for patient with receiving the mechanical security support, and it's also useful to guide when you are going to withdraw the mechanical security support, and also assess the candidate that you plan for advanced heart failure treatment. So these are recommendations. And regarding the minimally invasive hemodynamic monitoring, the flow track, well, all of us know that this is much more easy to handle compared with the pulmonary artery catheter, because it is minimally invasive. You just need the arterial line. It can estimate the stroke volume of the patients. And with the stroke volume relation, you can determine whether the patient is brake responsive or not. And because you can estimate the stroke volume, you can also estimate the cardiac output from the stroke volume calculations. And if you put in the CVP, then it can provide more information, which is the systemic vascular resistance. And these are all the trials that being conducted for the flow track. It's proved that using the flow track in the stable patients undergoing on-pump or off-pump CABG, it showed that usage of this advanced hemodynamic parameter can shorten the ICU stay, the overall hospital stay, as well as shorten the mechanical ventilations significantly. And Ling et al. In 2023, 344 patients, AMI patients undergoing PCI, they use the hemodynamic flow track for the patients to give them aggressive hydration to prevent the contrast-induced nephropathy. And it showed that with this advanced hemodynamic, you can lower down the contrast-induced nephropathy significantly. And of course, this tool also got its own limitation, I would say. It can predict the fluid responsive quite accurately, I would say. But in terms of the vascular, those patients presented with a low systemic vascular resistance, then there is some degree of percentage error. For those patients who presented with vasopressia, I believe then you need to correlate your clinical signs together and interpret this result, because the accuracy will be subjected to all this low SVR. So when using this parameter, this advanced hemodynamic monitoring, you have to have your own target, what you want to achieve for the patients. For example, I always like to keep the mean arterial pressure of the patient. I'm no longer looking at systolic and diastolic. The only number I'm looking for the blood pressure is the mean arterial pressure. I always try to maintain between 70 to 80 millimeter mercury. For CVP, I maintain 8 to 12. And of course, if you've got the stroke volume variation, it's better. You just need to make sure the stroke volume variations is about 10 to 13%. The patient is not hypovolemic. And cardiac index, if you put the patients on inotrope, please remember you need to keep the cardiac index at least 2.2. And for the systemic vascular resistance, 800 to 1006. If you are using the SVRI, then it should be 1500 to 2500. And for the end organ perfusion rate, urine output at least 0.5 ml per kg per hour. And since you have the CVP there, you might as well double check, all these hemodynamic parameter with the mixed venous oxygen saturation. Aim for 60 to 80. And central venous oxygen saturation about 60 to 70. And lactate had to be less than 2. So these are the hemodynamic target I always aim for when the patient have a cardiogenic shock. And these are all the drugs. I'm sure you're all very familiar of all these vasoactive drugs. Please remember, all these things is double-edged sword. It can save the patients. It can also kill the patients. So if you can see here, all these vasoactive drugs is playing around by activate only a few of receptor here. Dopaminergic receptor, alpha receptor, beta 1 and beta 2 receptor. So you need to familiar with the property of all these vasoactive drugs before you use them. And to make life easy, I will usually classify this vasoactive drug into several groups: the inoconstrictor, vasoconstrictor, and inodilator. And based on the hemodynamic profile, you should be able to choose all these drugs to be used for the patient in the treatment of shock. And sometimes, even though with the vasoactive drugs, the patient still not improving. For example, after you titrate up to 2 or 3 inotropes, the cardiac index still very low, then it is time for you to escalate to the mechanical support. Another group of patients is that the blood pressure not bad after you titrate the vasoactive drug. But if you see the heart rate is too fast, sinus tachycardia about 130, 140, that one also not very good. So you might want to also escalate up. Worse still for the patient, after you start inotrope, there's a lot of AF, there's a lot of VT. You know that vasoactive drug is not the way to go, but mechanical circulatory support. So here show you several types of MCS. It can meant for the right ventricular support. It also meant for left ventricular support or both ventricle. And what I want to show you is that how good this mechanical support, how powerful. So if you talk about IABP, this is the weakest mechanical support. Can only produce to you 0.5 liter per minute of cardiac output. So if you measure the patient cardiac output, let's say it's 1, you put the IABP, it become 1.5. So by calculation, you know that with the IVB, the patient won't feel well. They will still in cardiogenic shock. So you need to choose your mechanical support according to the cardiac output the patient is still having. When you talk about Impera, it can produce up to 5.5 liter, tandem heart 4 liter, and VA ECMO, of course, is the most powerful mechanical support here, 7 liters, basically can take over the whole heart function. So of course, some of you may say, oh, it's very tough. Let's say everyone will put ECMO, then should be okay. I think it is fair answer also for you to say that. Okay, so I think I presented all the theory part. Let's move on to the case study. I will hope, some of you can, give me some feedback, kind of a two-way discussion rather than I'm the one who presenting here. So in this case study, I have, few questions to ask you. Hopefully you all can give a feedback, can bring out any discussion you want to. So just start with this case number 1. So this is an 18-year-old gentleman claim there's not non-medical illness. So it came in to the emergency department with a heart failure symptom and reduced effort tolerance and lower limb swelling, 3 months. And of course, during the admissions, the MYHA is class 3. And examinations, patient is mildly tachynic, blood pressure is good, 120/70, heart rate is 90, but he is in atrial fibrillations. And you heard the pan-systolic normal on the precordium, lung so far is clear, but check the lower limb is already pitting pedal edema up to the mid-shin. Of course, investigation done, X-ray on your right-hand side, cardiomegaly. All of us will agree the lung is very clear. In fact, there is no upper loop diversion, no back wings appearance, there is no APO there. So ECG, atrial fibrillations, left axis deviation, left ventricular hypertrophy, voltage criteria. Full blood count normal, kidney function normal. Now the bilirubin is 58, liver is congested with the ALT of 52, and T-pro-BNP is 4,700. So echocardiogram, as you can see, the video over your right hand side, the LA significantly big, left ventricle is big, and you can see there's a severe mitral regurgitation. And this patient also have a severe aortic regurgitation. So basically we are dealing with valvular heart disease here. EF is 57, but definitely in the patient with regurgitant valvular lesions, the EF is usually underestimated. So you expect his EF is about 40, maybe 35, it's not really that 57. Anyhow, the TAPC, the right ventricular functions look good, 1.8. So as usual, after admit to the hospital, we diagnose valvular heart disease with the heart failure. Started with IV diuretic. Day 1 admissions, symptom and edema improve, patient feel better. And day 2, refer to the surgeons. Surgeon saw, plan for the elective dual valve replacement. And the drug treatment was optimized during that time with the furosemide of 40 mg BD oral, predomperal 2, bisoprolol 1.25, and warfarin for the atrial fibrillations with the INR of 2 to 3. So looks good, everything at this point. So about the discharge on day 3, and suddenly your medical officer call you up to say patient kidney function doesn't look good. Why? Because the urea is increasing trend. Day 1, 7.9, day 2 is 9, and day 3 is 21.1. Creatinine also raised from 66 to now 447. This is definitely a significant jump. And of course, your medical officer is very competent. He say this is a worsening kidney function. stop all the medication because the BP a bit low at this time, 85 or 54 millimeter mercury. Did the VBG show the bicarb is good? 21.4, pH is 7.45. And did the ultrasound try to exclude the kidney causes of AKI? There's no calculi, no prostate, normal kidney size. Uric FEME is normal. Regarding whether the patient got infection or not, well, the total Y is around 11, ESR 65, and the patient appeared febrile. And there is no upper GIT prick to explain the uremia. Hemoglobin is 15, PR normal. So these are the scenario. BP is borderline, house rate is 80, urine output is very bad. In fact, now it's already uric. JP is raised, lungs clear, no PD edema, tongue and skin a bit dry according to the medical officer, and capillary filling time is about 2 to 3. The kidney function as such, and the problem we are facing now will be the worsening renal function and hypotension. So what do you think? You know, causes of hypotension, worsening renal functions, hypovolemic, cardiogenic, or do you think there's some vasomotor dysfunction here? So can I have the the input from you all? Hello.
Yeah. Dr. Teoh,
yes.
Do this patient have a bedside IVC scan or a lung scan as well?
Lung scan, unfortunately, don't have.
Febrile, right?
Febrile. Total Y is is 11, ESR 65. Oh,
yeah. So day 3 of admission. Not sure whether it's a hospital acquired.
Yes.
One of the link here. I think we probably are dealing with cardiogenic with I'm not too sure whether there's any distributive involvement. Looks like patient volume is definitely it's overloaded, although the lungs is clear, but hemodynamic is quite congested. The BNP is quite high, even with the setting of the kidney is normal. So I think we are dealing with poor perfusion to the kidney that leads to the patient's poor urine output and renal impairment. So more of cardiogenic to me, but of course, I also like to know whether there's any distributive components that concomitant infections that may have set in. So to me, it's more of cardiogenic. Yeah.
Okay. So Dr. Joshua think maybe there's element of sepsis, day 3, I think it's just the correct timing for the nosocomial infection to set in. Dr. Ling would think, this is cardiogenic lah, since the patient's valvular heart disease, JP still raised, or the kidney cannot be, having so fast, must be cardiogenic, only can cause this type of thing lah. So, any other input? Hypovolemic, anyone? Maybe, our medical officer is too aggressive, try to dry the patient up within, 3 days, want to discharge the patient as soon as possible. They say tongue and skin a bit dry, doctor. The capillary filling time also 2 to 3 seconds like that. Yeah, kind of got borderline for you, to make your life difficult, So of course, at this point of time, we don't know. So I think some of you would think of maybe it's hypovolemic. Let's give a try lah, no harm, I think. So we stop the medicine and then we give the zolapandin. Be generous a bit, give 2 pints straight away, 1 liter of zolapandin. Yeah, after given the zolapandin, the blood pressure is still 90 or 60, just increase maybe by 5 millimeter mercury, and heart rate remain the same at 85. Now check, hey, Dr. Joshua, still febrile, no fever, but the urine is still oliguric and JP is still raised. Lung is still clear, no PD. Now the tongue moist already. Yeah, a bit hydrated now. And capillary filling time 2 seconds. But now the urea worse already, 23 from 21. The creatinine now is 500 now. So go back to our chart here. How? maybe we should take the opinion from Dr. Ling again. Dr. Ling think it's a cardiogenic. Okay lah, cardiogenic lah. Let's start a bit of dopamine here lah. Titrate up to 5 mic per kg per minute. And you can see the blood pressure start going up a bit. Another 5 millimeter mercury systolic. And of course, because of the dopamine, you expect the heart rate to be faster now, 95. Patient is still afebrile, but still oliguric. The physical examination almost the same, except the capillary filling time is better now, perfusion is better. But you check again, urea now is 25. Creatinine now is 547. So your MO say, boss, not responding, free and inotropes. What else? Dr. Joshua?
We need EV 1000.
Correct, I think. So we are start thinking, maybe infection. Although fever, I think, fever, infection can present without fever, right?
Yes.
And maybe some people will think of maybe the free is not enough. Or maybe Dr. Ling will think that dopamine 5 only should set up to 10. What do you think? Or add in another dobutamine and try and see. So of course, because of this patient having an aortic regurgitation, right? Your EV 1000 cannot, I would say, not suitable to be used in this patient. Any things that can alter the arterial waveform can cause your EV or flow track become inaccurate. So it's not accurate at all. So if you've got the IBP that augment the diastolic phase of the arterial waveform, or you got the aortic regurgitations, this thing is not suitable anymore. So we put in the Swan-Gun catheter. You can see here the catheter inserted through the right internal jugular, and the tip of the catheter is parked at the place that we can wedge the pressure. And after the Swan-Gun insertion, we can obtain this hemodynamic parameter. Now the CVP is 19. Well, I would say the free is enough already. Cardiac index is 2.32, which is, I would say, satisfactory. Wedge is 14. Basically means that the left heart is still okay. And show you the systemic vascular resistance 662, which is low. So actually we are dealing with vasodilatation. Of course, you ask what is the cause of vasodilatation here. I say maybe it's sepsis, maybe the perilumpia is causing a so great vasodilatation. But actually, I don't know what happened. Anyway, we covered the patient with antibiotic as well. And we started the noradrenaline. Titrate up the dose to 0.1 mic per kg per minute. And during the titrations, we wean off the dopamine. And managed to maintain the blood pressure quite well, 105, 60, pulses 75. Afebrile, now urine output is good. The CP went down to 8, cardiac index maintained, SVR went up to 1005, and your urea improved, creatinine improved. So at this point of time, we are very happy. Okay continue. So maintain the patient on NOAD 0.1, but sometimes thinking if you increase the systemic vascular resistance, you're actually vasoconstricting, right? So this is not the good thing for the weak heart. If you increase, your heart need to pump harder to get through the afterload. So this is what happened. After we maintaining 1 day of noradrenaline, the BP is okay, pulse is okay, but the patient become oliguric again and start to have congestions, lung congestions. And you can see here, the CEP went up, the cardiac index dropping. Now your left ventricular pressure is going up, the feeling pressure, which become 18. And SVR now is 1962. Too much of vasoconstriction, causing the left ventricular overload. And urea worsen again, creatinine worsen again. And at this point of time, we start back the dobutamine 3 and wean off the noradrenaline. BP beta, afebrile, good urine output, all the parameters went back to normalize. urea is better, creatinine normalized. And discharge well on day 8 after tapering off the inotropes. Start back all the medications, furosemide, ranitidine, bisoprolol, and warfarin, and a plan for elective dual valve replacement. So this is a case summary. 18 years old, valvular heart disease, at first heart failure, progressed to AKI because of distributed shock, which responded well to the noradrenaline. But subsequently, because of the increase in the afterload, there's a low cardiac output with congestions, and the switch the inotropes to inodilator, and the patient become better and able to go home. So I would say the summary of this case, the things I can learn is, well, I would say the hemodynamic tend to change so fast. So understanding the underlying pathophysiology can guide you which vasoactive drug you need to use so that patients can have a better outcome. Yeah, this is the case number 1. Any comment or any questions you want to ask? Well, if there's no questions, I think my time's up. So I will just stop here, or Jack, what do you think?
You said another good case to check?
Yes, of course, but I think my time is up already.
Dr. Teoh, share one more case. A very good case, Dr. Teoh.
Okay. Yeah, so this is case number 2. 73 years old Malay lady, dyslipidemia. Now, it presented with the epigastric pain 4 days prior to the admissions. Of course, associated with reduced effort tolerance, partial nocturnal dyspnea, and autopnea, all very typical signs of heart failure here. And examinations, typical crepitation up to the mid zone. Now the type 1 respiratory failure with a PO2 of less than 50, but the blood pressure is okay, 135, 111 millimeter mercury. So of course, the emergency department there do the initial workup. ECG shows sinus tachycardia 124, already deep QA with ST elevation and delete. So, but this is 4 days history already. So trop-I 6,000 and NT-proBNP is 9,000. So do a bedside echo, EF is 21%. Normal left ventricle size, but the LAD territory already look like infarcted already, akinetic and the wall. So based on the history, you know that this is the patient with the established anterior MI, and most likely the LAD territory is already impacted. Now came to you with heart failure, purely heart failure. I don't think you can go in to do the primary PCI because it's really 4 days duration, so you can't really, improve the myocardium. So diagnosed to have heart failure, APO, admitted to CCU, start on the NIPPV, furosemide, IV and TG infusion, standard treatment for heart failure. And this treatment has been continued until day 3 of admission, whereby the patient's actually not doing good, not doing better, but progress into cardiogenic shock. The blood pressure is lowish, acute kidney injury set in, and oliguria again with a 350 cc per day of urine output. And of course, switch the nitroglycerin to dobutamine, 3 mg per kg per minute. But after starting this dobutamine, the BP still remain lowish, but causing more problem, frequent non-sustained BT. And because of the patient's EU conditions, decided for elective intubations, but this patient is complicated with the peri-intubations PEA, and that the patient need to be resuscitated, and there's a return of spontaneous circulations. Now, when the patient is sick, or sometimes I think we need to tell our anesthetics colleague, try not to use the usual muscle relaxant that can cause vasopressia to the patients. Sometimes I ask them, you better use ketamine or something that won't drop the SVR so much. Sometimes you just give the induction and straight away the blood pressure drop and then there's no cardiac output, then they need to resuscitate the patient, which is quite bad to me now. The patient already very bad, you add the problem to the patient again, the patient usually can't survive. So anyway, this happened to the patients, peri-intubation, cardiac arrest, resuscitated, and then they need to start the CVH for the patient because of the blood pressure too low with the AKI and oliguric. So at this point in time, they are not comfortable to manage again. They straight away refer to the heart failure team, ask for help to see what can be done for the patients. So these are the scenario here. The CVH or extraction on day 3. After the resuscitation, these are the inotrope dosage. Dobutamine is 15 mic per kg per minute. Noradrenaline is 0.05 mic per kg per minute. And mean arterial pressure 67, heart rate 110, CVP 17, and uric. At the time, there is no hemodynamic monitoring yet. But I went and see the patients. First thing I did is to touch the patient legs, and I touch it, it feels very warm, very warm. It's not the typical kind of cardiogenic shock here. Very warm and perfusion is very good. So I think this one is kind of like a vasodilatation, perhaps a vasopressia. Who knows what is that? Maybe due to NTG, due to the sepsis, or due to the anesthetic agent. I'm not sure which one, but I'm sure the patient got this vasodilatation. So what I did is basically I said, hey, increase the NORAD and then taper down your Dobu, because you have to know that dobutamine stimulate both the beta 1 and beta 2. So inodilator is cause inotropic effect. It's also cause vasodilatation. So if you add both the effect together, what do you think the blood pressure will go? Either go up or go, I would say the blood pressure will be either similar or some of the patient will drop because of the vasodilatation effect is much more, is greater than the inotropic effect in dobutamine. So be careful when you use this inodilator. Not all the inotropes increase blood pressure. Some of the inotropes drop the blood pressure, especially inodilator. Example like dobutamine, mirinone, and levosimendan. So for the patient with low blood pressure, be careful to use this inodilator. Those inotropes that can increase the blood pressure will be the dopamine, adrenaline, and noradrenaline. So usually for those patients with hypotensive one, I seldom use inodilator. Or if I want to use inodilator, usually I will put one vasoconstrictor together, to counteract, the vasodilatation effect from the inodilator. So this is what I did. Increase the noradrenaline from the 0.05 to 0.15 mic per kg per minute. And I asked them to tune down the dobutamine according to the mean arterial pressure, try to maintain between 70 to 80. So this is what they did. The nurse very well increased the NORAD up to 0.15 and taper off the Dobu. And he managed to maintain the MAP 76 to 78. Of course, if you increase the NORAD, you reduce the dobutamine, you expect the heart rate will go down from 100 to 88. And cardiac index increased 2.1 to 2.2. And now you can see the systemic vascular resistance is increasing from 1002 to 1004. And what happened is that, of course, our hospital got, a lot of doctors, a lot of teams, some of them may not, agree with the decision made. They think that this patient is having cardiogenic shock because the EF is low, patient just have the AMI. So increase back the dobutamine to 3 and tune down the noradrenaline. So if you do like this, you know what will happen? I need some, I need some feedback. What do you think will happen to this patient? You add in the dobutamine and you reduce the noradrenaline. Dr. Joshua? since you are the closer person to me.
Yeah, I think the MAP will drop because of the inodilator. You give a bit of inotrop, but your at the same time you vasodilate and you reduce the vasoconstriction some more.
Yes. So what happened to the cardiac index?
Cardiac index will improve a bit, but the MAP will drop.
MAP drop and SVR will drop.
Correct.
Correct. Okay, so this is what happened. Wait, yes, so MAP drop. Yes, you're right, Dr. Joshua. And of course, the heart rate increased 100 now. And if you can see here, the cardiac index perfect, 2.6 already, but your SVR stopped dropping. And after that, what happened is that the blood pressure dropped too much. They have to stop the CVVH, and everyone become panic. So give some free challenge a bit, because you know, panic already. Give some free and see whether the BP pick up or not. It's still the same. And then of course, the patient is still fluid overload. So start on the furosemide infusion, because the CVVH cannot restart again because the BP too low. And what happened is that still think of the cardiogenic shock, reduce the NORAD further to 0.08, add in the levosimendan, which is another inodilator, 0.05 mic per kg per minute, and add in another IBP 1-in-1 augmentation. What will happen if you add in the IBP for the patients? Well, understand the principle of IBP is inflate during the diastolic. It will deflate the balloon during the systolic. So it will some sort like increase the coronary perfusion, but it will drop the systemic vascular resistance further, so that your cardiac function can be better, the contraction can be better without so much of afterload. So what do you think happened to the patient? Dr. Joshua again. Sorry, I just know you.
It's okay. I think the SVR will drop further, despite with add on a levosimendan. Cardiac index, I think, will slightly improve a bit on it.
Okay, so of course the MAP dropped further to 59 because of the levosimendan, you know, the heart rate even faster now, 110. And like what you say, the cardiac index 2.8 now, and now it's already, you know, the SVR is too low, it's 718. And eventually, you know, the blood pressure dropped too much, vaso 2 is added. But I think at this time of point, the patient really not well, and the blood pressure too low, cardiac index also drop, even though you can bring up the SVR a bit, but it's too late to do anything. After the patient developed asystole, like usual, CPR performed. I don't think you can save the patient anymore. Total adrenaline is 10 mPu given, passed away after 30 minutes of resuscitations. So this is another case to illustrate to you hemodynamic tools by itself cannot change the outcome of the patient. The doctor is the one who can change the outcome of the patients. How do you change the outcome of the patients? Three important points here. You need to interpret the hemodynamic parameter correctly, and you need to have a goal-directed protocolized therapy. What to give during the vasopressia, what to give during the cardiogenic, what to give during the hypovolemic shock. Written it in the algorithm. Although I would say it's not one size fits every patient, but you try to, you know, try to think common sense and then try to work out in the rational way. I think definitely you can save the patients. And of course, you need to pick the appropriate patient populations, which hemodynamic tool for which patient. And of course, with that, I would say you can improve the outcome of the patients. And of course, very, very important, a careful selection of vasoactive drug, including the mechanical support, is very important to avoid the side effect from the medicine. Yeah, I think this is my second case. Thank you very much. Any questions?
Dr. Teoh.
Any question from our side?
No question, Dr. Teoh. I think very well presented, Dr. Teoh.
Oh, thank you very much. So I will just unshare the